more seconds to do that. And then moving on, if you can select the category or role that best describes you. And again, these results will not be shown. Right. Just give you a few more seconds for this one. And then moving on. In the care of approximately how many patients with MS are you involved each month? So how many MS patients on average would you say you see on a monthly basis? So if you can please select your response. Just get a few more seconds and then move on to the final question. Which of the following practice settings is applicable to you? And if you can please, again, select your response. All right. So that's it for the kind of general demographic questions. And I'm just going to be moving into polling questions that we will revisit during today's symposium. So right now, I won't show the results of these questions, but just so that we can get an idea of what your thoughts are on these topics, if you can select what you think is the most accurate response, which of the following statements about the role of MRI in MS care is most accurate? Number one, its primary function is in MS diagnosis. Number two, MRI is most useful to record quantifiable evidence of brain volume loss. Number three, MRI can detect MS activity before clinical changes are detectable. Number four, fluid biomarkers are on track to make MRI obsolete. Or number five, I'm not sure. So if you can please enter what you think is the most accurate response. Okay, so we'll move on to the next question, and there's 3 of these questions total, so this is the second. Which of the following statements about the central vein sign is most accurate? Number one, it has been validated to reliably distinguish MS from other white matter diseases. Number two, it has not been assessed in prospective studies. Number three, it can be readily evaluated on a 1.5 Tesla MRI platform. Number four, it is no longer considered a promising diagnostic measure. Or number five, I'm not sure. If you can please enter what you think is the most accurate response. We have a real Nashville theme going here with the background music. All right. Okay, so this is the final question, and again, these 3 questions will be revisited during the talks that both Dr. Bar-Or and I will give. Which of the following statements about neurofilament is most accurate? Number one, while not an MS-specific marker, NFL can be clinically useful in detecting CNS damage in MS. Number two, rising serum NFL levels are a validated indicator of elevated risks for progression independent of relapse activity, or PIRA. Number three, CSF NFL levels are less sensitive than serum NFL levels in detecting CNS neuroaxonal injury. Number four, serum measurements of NFL are expected to eventually replace MRI in monitoring MS disease status. Or number five, I'm not sure. If you can please enter what you think is the most accurate response. All right. Thank you very much for your participation. I know it was a lot of questions. Okay, so I am going to start by talking about MRI, what's new with the tried and true. And so I actually only have less than 20 minutes now, but I'm going to take you through how MRI is used in clinical practice, and then take you through some emerging MRI measures that may actually make it into the clinic in the near future for specific purposes. So I think it's not an exaggeration to say that MRI has really revolutionized the diagnosis and monitoring of people with MS. It is by far the most valuable paraclinical tool that we use. And while it's not essential for diagnosis, it is probably essential for disease monitoring. But even for diagnosis, except in settings where an MRI absolutely cannot be performed, it probably is essential in most. And so how has MRI revolutionized clinical care in MS? Well, it allows us and most people with a first clinical presentation to diagnose earlier. It's also the most valuable tool that we have for disease monitoring and assessing treatment response. And one of the great challenges we have in clinical practice in MS is accurately predicting how an individual patient will do. Most people with MS present in their late 20s and early 30s, typically have a relapse and then get better. And so as you can imagine, it's very challenging to know who will develop highly active disease versus those who may have milder disease. And obviously there are a lot of treatment decisions around this, and it turns out MRI is actually one of the most valuable tools that we have for prognostication. In addition, from a scientific standpoint, it has contributed substantially to our understanding of MS pathophysiology. And so for all of these reasons, I think it's pretty clear that it really is an indispensable tool from both a clinical and scientific practice in MS clinical care. As you know, this is the latest version of the MS diagnostic criteria, and MRI plays a very important role in the diagnostic criteria, and this is because it's a paraclinical tool that allows us to very easily demonstrate the clinical hallmarks of MS, which are dissemination in space and time. So as we know, MS is a chronic neuroinflammatory, neurodegenerative disease, and it is a disease that lasts for many years, if not decades. From a clinical standpoint, because the hallmarks are dissemination in space and time, before MRI was widely available, in order to diagnose an individual with MS, clinicians had to demonstrate that an individual patient actually had relapses or attacks that were spaced out in time and also affected different parts of their central nervous system. But using MRI, we can now actually very easily, often with the first MRI, demonstrate evidence of dissemination in space and time. And how we do this is outlined here. So in order to use MRI to demonstrate dissemination in space, you can do this by simply demonstrating that there are lesions present in at least 2 out of these 4 typical locations where we usually find MS lesions, which include periventricular regions, juxtacortical or cortical, infratentorial, as well as in the spinal cord. And then you can also use MRI to demonstrate dissemination in time in 2 ways. So if gadolinium is given with the first scan, and so it is highly recommended with the diagnostic scan, what gadolinium enhancing lesions represent are simply lesions that have formed acutely, usually within the last 30 days. So if on that first initial scan you can just demonstrate that there are lesions that enhance and those that do not, right there you've automatically demonstrated that there are lesions of different ages in that individual patient, so you've demonstrated dissemination in time. Or if you happen to have a baseline scan and another scan at any time point after that and demonstrate the presence of a new T2 lesion, then you've been able to very quickly demonstrate the presence of dissemination in time. And so this is why MRI is such a valuable diagnostic tool, because again, these clinical hallmarks using MRI can be very easily demonstrated. Knowing how important MRI is in the diagnosis and disease monitoring of MS, there are a number of groups, imaging groups around the world that have come together to put together consensus guidelines on how we should optimally use MRI in the clinical care of MS. And the latest version was published in 2021 and led by Mike Watchis and Alex Rovira. And as you can see here, there are many recommendations on the bare minimum standardized MRI guidelines that should be used for clinical care for both diagnostic as well as disease monitoring purposes. For those of you who are at the MRI course that was given on Wednesday, the interesting thing is, despite the fact that these are recommendations that have been endorsed by, as you can see, Magnums, CMSC, as well as the North American Imaging Group, when you actually poll centers that see larger volumes of people with MS, less than 20% of these centers are actually adhering to these guidelines. So I think really important to note that we obviously use MRI as an indispensable tool in clinical care in MS, but it's important to make sure that MRIs are adhering to these bare minimum standardized international guidelines. So these are just slides summarizing what some of the guidelines include, and I would really encourage you to look up this reference if you're interested in seeing some of these specifics. But there are, again, bare minimum recommended and optional guidelines for how you should acquire brain MRIs and how you should acquire spinal cord MRIs for diagnostic and disease monitoring purposes in MS. So I think it's very clear that MRI plays a very important role in the diagnosis of MS, but another really important role that MRI plays in clinical care is that it is probably one of our most useful tools that we use in addition to clinical judgment to monitor for disease activity. And this is because, like many neurological diseases, MS really fits this iceberg analogy in that from a clinical standpoint, what you see on the surface clinically is really but the tip of the iceberg of what is actually happening with respect to the disease process within the central nervous system. And studies that have been done show that MRI lesions develop up to 10 to 20 times more frequently than clinical symptoms in people with MS. And so despite the fact that it's very important, obviously, as clinicians that we see our patients regularly, the way we screen for MS disease activity, which is really asking people if they have had symptoms suggestive of a relapse, using our neurological exam in clinic, it's clear that this is not sensitive enough in any way. And this is why it's so essential to use MRI as a tool to monitor for subclinical disease activity. And generally, most recommendations are that clinicians should perform MRIs on, at minimum, an annual basis in people with relapsing MS, and sometimes even more frequently when there are treatment initiations or switches, or if there's concern about very active or aggressive MS. Based on the fact that we now recognize as a field how important it is to monitor people with MS regularly, both clinically as well as using MRI, there have been many guidelines developed around the world, and because I'm Canadian, I did put up the latest version of the Canadian treatment optimization recommendations, but there's many recommendations around the world that really follow the same theme, in that when you monitor people closely, and if they are developing evidence of concerning clinical disease activity as well as MRI disease activity, treatment should absolutely be optimized. Now, the specific threshold of how many new lesions is worrisome varies depending on the guidelines, and I don't think there's anything really magical about, say, in the Canadian guidelines we landed on, if you have three or more new lesions while on treatment, this is of high concern. But I think the bottom line is, regardless of whether it's 3 lesions or 5 lesions, when an individual is developing evidence of many new lesions while on treatment, this is someone where treatment should be optimized. This is another example of a treatment recommendation, the modified Rio score, which similarly to the Canadian guidelines looks at how many new lesions and relapses people are developing while they are on treatment. And in this particular guideline, when an individual develops 5 or more new lesions, this is of high concern and highly associated with the risk of additional relapses as well as disability progression over time. So I think in a nutshell, regardless of what guideline you look at and the specifics, it's very clear, again, when somebody has evidence of clinical or significant MRI disease activity while they're on treatment, this is someone where treatment needs to be escalated. So we're going to go back to that polling question that I asked you earlier. Based on these discussions, if I can ask you to vote again, and again, please use the remote controls on your tables, which of the following statements about the role of MRI in MS care is most accurate? So if you can please vote. Right. We'll just give it a few more seconds. Great. All right. Okay, so I see that the majority of people have voted for what we thought was the most accurate response in that MRI can detect MS activity before clinical changes are detectable. However, a proportion did also vote for MS diagnosis, which is also not untrue. However, I would say, one of the functions of MRI is definitely in the diagnosis of MS, but particularly with emerging evidence, another huge role of MRI in clinical practice is for disease monitoring. Okay, so thank you for your responses. So moving on, I'm just going to talk about another great utility of MRI in clinical practice. So we very clearly discussed how useful MRI is in diagnosis. We just discussed how important MRI is to monitor for disease activity in MS. And another great utility of MRI in clinical practice is prediction or prognostication, which we know is a great unmet need in MS clinical practice, because as I alluded to earlier, when an individual is presenting for the first time, it's really tough to know which people should be on the highest efficacy therapies from the very beginning of disease versus which people might be fine on platform therapies or maybe even without treatment. And so prognostication or prediction is somewhere where we really need help. And you'll probably have read many articles over the years that have these giant tables of many different clinical and demographic factors that we as clinicians use to try to prognosticate in individual patients. And so among all of these demographic and clinical factors, I think one of the most definitive studies that has proven the utility of MRI and prognostication is a study that was done by the Barcelona group looking at people presenting for the first time with clinically isolated syndrome. And these individuals were followed very closely over nearly a decade. And as you can see here, from amongst all of these different demographic and clinical variables that have been shown in different studies to be associated with a worse prognosis, as you can see, it was really mostly the baseline MRI lesion load that was most predictive of developing another attack over time or developing increasing disability over time. The presence of oligoclonal bands as well was associated with a worse prognosis, and then age was also a factor, but as you can see, by far, it was really the baseline MRI lesion load. So I think this is very informative, and another reason why MRI is so useful for prognostication, particularly at the very beginning of the disease. And this is that same study showing that individuals with a higher baseline MRI lesion load have a much higher risk of eventually developing another relapse and having MS, as well as reaching specific disability milestones like an EDSS of 3. In addition, spinal cord lesions have predictive value as well, and this is a study that was done by the UK group that looked at nearly 200 people with clinically isolated syndrome and followed them for 15 years. And they found that amongst, again, baseline demographic and imaging measures, it was really having a spinal cord lesion or developing new spinal cord lesions over time that were most strongly associated with the risk of secondary progressive MS. So as you can see, from a prognostic standpoint, the baseline brain MRI lesion load and the presence of spinal cord lesions is very useful because both of these suggest that an individual may have a worse prognosis, and obviously in clinical practice this can have treatment implications. So I hope I've been able to summarize for you how useful our typical clinical MRIs are in clinical practice for diagnosis, disease monitoring, as well as prognosis, and then just want to take the last few minutes to talk about a number of imaging measures that may become useful very soon in clinical practice. And here I've listed not an exhaustive list at all, but many different advanced, more quantitative imaging measures that have been in development with different groups around the world. But it's been very challenging to bring any advanced imaging measure into clinical practice. And if you think about it, we've been measuring brain volume and brain atrophy in clinical trial settings now for over 2 decades, yet we don't really routinely use this measure that has been studied for a really long time in large groups of patients in clinical practice. And so there's a lot of reasons for that. There's logistical challenges with some of these fancier techniques. You need to have appropriate sequences, you need to have appropriate software, you need to have appropriate engineers and physicists that can develop these software techniques. And so these are all of the reasons why it's been difficult to get some advanced measures into clinical practice. practice. And another big challenge is that when you say have a measure of brain volume, it's difficult to know exactly what threshold should be the cutoff when you act. It's different from monitoring for new MRI lesions because, we have these numbers of if you develop a number of new lesions over time, this is concerning. But as you can imagine, if you have measures of volume, it's difficult to know at exactly, how many milliliters of brain volume you start to get worried. And so these are all of the reasons why it's been difficult to bring any of these more advanced techniques into clinical practice. However, there are some emerging MRI measures that may finally actually make it into the clinical realm. And this is because they're not that difficult to get. And some of these measures are actually very easy to visualize just on a scan. And so one of these measures, and you've probably heard a lot about it, but really very quickly, the central vein sign is something that has interested many in the field for at least over a decade. And many different studies have accumulated over time. And what this is when you use MRI sequences that are sensitive to iron, when a white matter lesion has formed around a central vein, you can actually visualize that central vein. And the reason why in MS we're so interested in this is because the pathophysiologic hallmark of lesions that form in MS, it's because it's related to perivenular inflammation and demyelination. And so we know that in most lesions in people with MS, they should have formed around a central vein. So now we have a way to visualize the central vein if it's there. And so this is why it's very interesting and why this may become a very useful diagnostic biomarker of MS. Right now, we're pretty good at MS diagnosis with the tools that we have, but misdiagnosis can be a major issue, and this is a tool that may help us to prevent misdiagnosis. So what people have found is that when 40% or more of white matter lesions in an individual patient have visible central veins, the likelihood of a diagnosis of MS is very high. And so if we are able to access these appropriate iron-sensitive sequences, this may be a really useful tool because radiologists will be able to look at a scan and say, this is somebody where the majority of white matter lesions that we see have a central vein, therefore the likelihood of a diagnosis of MS is high. As you can imagine, though, if somebody has like 50 or 60 lesions, it's a bit of a pain to go through each lesion to try to see if there's a central vein sign or not. And so there's simplified criteria now, like Select 3 or Select 6, where if you can show that there are 6 lesions and they all have central veins, the likelihood of a diagnosis of MS is very high. So this is something that you'll probably be hearing a lot more about. There was a group of neurologists from around and radiologists from around the world very recently that met to talk about revising the MS diagnostic criteria, and this was one of the imaging measures that was discussed in quite a bit of detail. So these are just some slides showing that there have been many studies over time showing that the central vein sign is useful to distinguish MS from other white matter diseases, but there are still, as I alluded to earlier with most advanced imaging techniques, some practical concerns in that the highest sensitivity iron-sensitive sequence, which is the 3D T2 star EPI sequence, actually is currently not clinically accessible without signing cumbersome research agreements. Most of the studies that have been done have used higher field MRIs, like 3 Tesla or 7 Tesla platforms, and around the world, 1.5 Tesla platforms are still the most common. In terms of these threshold issues, it's not clear what the optimal threshold is, but it does seem that some of these simplified rules like Select 3 or Select 6 are still pretty good. And then there's not a huge amount of prospective studies that have been done yet, but many of those studies are underway. So still some practical concerns, but as you can see, it is very interesting and intriguing just because this may be an imaging biomarker that is highly specific for MS that may make it into the next version of the diagnostic criteria. So based on our discussion, if I can ask you to revisit this question. So this earlier polling question of which of the following statements about the central vein sign is most accurate? So if you can please enter your response now. All right, excellent. So it seems very clear that most of you voted for what I think is probably the most accurate answer, which is that based on accumulating studies over the last 10 years, it has been validated to reliably distinguish MS from other white matter diseases. All right, so moving on. To the last portion, and I know that I'm cutting into a meets time, and I most definitely don't want to do that, so I will go through this really quickly. So another imaging biomarker that is still mostly in research settings, but may have promise for different clinical purposes is something called paramagnetic rim lesions, or PRLs or PEARLs. And again, this is using iron-sensitive sequences when a lesion has a rim of activated microglia around it, and activated microglia tend to be high in iron content. When you use the appropriate iron-sensitive sequences, you can detect a rim around some of these chronic lesions. And the reason we care so much in the MS field about this is because these have been histopathologically validated to represent chronic active lesions, which is a major driver of progressive disease biology, or CNS compartmentalized inflammation. And so it's very intriguing from a scientific perspective, as well as from being able to monitor progression perspective. But it turns out paramagnetic rim lesions are also highly specific for MS. So if you visualize a paramagnetic rim lesion in somebody, the likelihood of a diagnosis of MS is very high. And so for all of these reasons, because it may be a useful imaging biomarker of progression, and because it is highly specific for MS, there is a lot of interest on paramagnetic rim lesions in the field. This is just a slide summarizing studies that have been done that show that having a large number of paramagnetic rim lesions is associated with greater greater physical and cognitive disability. And paramagnetic rim lesions have been visualized across the entire spectrum of MS, even in people with RIS, but there are just larger numbers or larger proportions of paramagnetic rim lesions in people with later stages of MS. Finally, another imaging biomarker that you've probably heard a lot about are slowly expanding lesions, or SELs, or cells. And this is another way that we think we may be able to capture these chronic active lesions. Cells are an interesting technique just because you don't need a fancy iron-sensitive sequence, and you can actually just use regular T1 and T2 based sequences on 1.5 Tesla scanners, but you do need longitudinal scans. And so when you monitor an individual patient longitudinally, and there's a lesion that very slowly expands in a concentric manner, this is detected by the computer algorithm as a slowly expanding lesion. And although it's not specific, obviously, for chronic active lesions, as you can imagine, this is a technique that allows us to detect at least a proportion of these chronic active lesions, and is of interest because, again, as a field, we are looking for an imaging measure that allows us to better monitor progression in MS. So with that, I'm just going to take you through a clinical case that we will revisit again throughout the course of this symposium and discuss in this setting what might be useful. So this is actually a patient of mine. This is Sierra, who's 29, and was diagnosed with relapsing MS 6 years ago at the age of 23. Initially, she had pretty active disease because she had 2 relapses in 18 months. She had residual disability, so motor as well as cerebellar disability after these 2 relapses. And very early on, she had a heavy MRI lesion burden in both the brain and spinal cord. So based on all of the things we discussed about prognostication, obviously I was very worried about her, and then started her on a high efficacy therapy. So in this case, it was ofatumumab. And on ofatumumab, she has not had any relapses, and her MRIs have been perfectly stable on an annual basis. However, in the last year, she reports to me that she just doesn't feel as well. She tells me that she feels like she's slowing down over the last year or two. And then when I examine her, obviously in clinic, her EDSS score is completely unchanged. However, when I ask her to describe what she means, she tells me that she used to comfortably hike 6 to 8 miles on hilly trails, and now she can barely handle 4 to 5 miles on flat courses. So despite the fact that all of my clinical tools are telling me that this patient is stable, very clearly she is not. And so this is an individual that I think is demonstrating progression independent of relapse disease activity, or PIRA. And again, this is something that you've heard a lot about. And then when I asked myself what MRI measures might be useful to evaluate her, I did discuss with you a number of imaging measures that we hope in the future, with appropriate validation and access and all of these other kind of logistical issues we discussed, we might be able to use, like PRLs and cells. At this point, there really is not very much that we can use clinically. I know that this is somebody who seems to be very slowly progressing. Even the clinical tools that I have can't really detect it, but I know this is the case based on what she's telling me. I would obviously perform another MRI just to make sure she's not developing new T2 lesions, the typical tools that we use in the brain or spinal cord. But if all of that was stable, at this point, unfortunately, I don't think there's a very clear imaging biomarker that we can use. But hopefully this will change in the coming years. And so if I can first ask Amit, any thoughts about this? Is there anything else from an MRI standpoint that you would do?
I think you're absolutely right, Jiwon. I mean, this is one of those situations where you would look as comprehensively as you can to detect any evidence of new focal inflammatory activity that would suggest relapse biology. She is on a high-efficacy therapy, one of the anti-CD20 therapies. It would be unusual but not impossible. But in the absence of that, you're looking at someone who's likely having slow, smoldering disease, and we don't, to date, have good imaging markers. We'll talk a little bit about the fluid biomarkers in that context as well, which may someday, hopefully soon, give us an edge as well.
So you very nicely segued into your portion of this symposium, where we'll be now talking about some fluid biomarkers. So this is just a general summary of all of the imaging discussions that we've had to date, and I will hand over to Dr. Bar-Or, who will talk about blood, CSF, and beyond, looking at emerging biomarker strategies.
Thank you, Jiwon. Good morning, everyone. And so Jiwon has superbly overviewed both the standard clinical aspects of MRI application in the clinic, as well as some of the emerging assessments that can be hopefully one day soon translated into adding value to what imaging can do in terms of understanding the state of patients, and had made the point about the prospect of using tools, biological measures that can give us some meaningful insight into clinical discussions for A, diagnosis, B, assessing the state of an individual in terms of is their MS active, less active, and prognostication, what is the prospect for this individual down the road, off treatment or on treatment. And so we do recognize the need still of some additional clinically useful assessments, and one of the areas that's been pursued quite actively over the last few years relates to fluid biomarkers. And questions that we can ask ourselves is, what is the utility now and hopefully further in the future to look at either blood, serum or plasma, or spinal fluid to help further support a diagnosis of MS, to assess again the disease state, monitor disease activity and or progression, and potentially provide prognostication. This list is of a number of proteins that have been studied as potential fluid biomarkers. And the list is already relatively long and growing, but we won't focus on all of them here for the sake of time. The ones that have been studied to date most comprehensively are neurofilament light chain and glial fibrillary acidic protein, or GFAP. NFL and GFAP are the ones that we'll be focusing on. What Dr. O will follow up on is some discussion about very interesting assessments looking at eye tracking, eye movement tracking, as well as digital measures that may complement our capacity to assess the status of patients over time in the clinic. And importantly, almost certainly we'll be looking at combinations of MRI with whether fluid markers, digital measurements, et cetera, to give us a better sense of the state of an individual and their experience with MS at any point in time. We'll start with neurofilament light chain. And many of you are already, I'm sure, aware that neurofilament light chain can be released by neurons and their axons partly as normal turnover, so healthy individuals will have some neurofilament light chain detectable in their blood, but in the context of injury, anywhere along the neuroaxonal unit, meaning the cell body of the neuron and its axon, will result in spillage of the neurofilament. It will end up in the spinal fluid, and then it may leak out into the blood. And we have initially been able to measure it in the CSF and had difficulty as a field measuring it in the blood. Fortunately, with the development of several more sensitive and specific tools, individuals, you can see now a very good correlation on the right-hand side between serum measurements on the y-axis and CSF measurements of neurofilament light chain, or NFL, and a very, very good correlation. So measuring in the blood seems to correspond well to what is present in the spinal fluid, and what is in the spinal fluid is thought to represent injury in terms of the central nervous system. And in fact, it's not only the MS field that has been very interested in NFL as a potential assessment of injury to the central nervous system. You can see that in Alzheimer's disease, ALS, Parkinson's disease, and trauma, those are fields that have been very actively studying and increasingly incorporating NFL into their armamentarium of trying to assess patients. That said, and while blood NFL level, which is shown in the center, can be a reflection of central nervous system damage, peripheral nerve damage can also elevate circulating NFL. And multiple other aspects that are not MS-related can also elevate serum or plasma NFL. Aging is associated with an increased cardiovascular disease and other chronic illnesses, especially COPD. It can be associated with quite high elevations of NFL, including to levels that are within the range or even exceeding the abnormal levels that we detect in multiple sclerosis. Head trauma is another one, and other aspects that may impact the permeability of the blood-brain barrier. Increased body mass index and the state of pregnancy can also influence measurements of the NFL. That is to say that NFL may be a useful assessment or way of capturing some aspect of injury to the CNS, but we need to be cognizant that there are other things, non-MS related, that can also result in indistinguishably increased levels of NFL. So not every increase in NFL in a person with MS necessarily reflects their MS course, and that is going to be one of our challenges. So it is a marker of neuroaxonal injury, but it is not MS specific. It may detect CNS damage, but we need to think of other potential causes, and there are now some platforms, a couple listed there, that measure NFL quite accurately in the accessible peripheral compartment, the serum or the plasma. An important aspect of a biomarker for it to be useful is whether it is responsive to treatment. And this data summarizes very nicely what essentially proves that neurofilament levels can respond to different treatments. And what you're seeing here on the y-axis is Z-score presentation or representation of the NFL levels in the serum. What a Z-score does is it essentially normalizes a person's measurement relative to the healthy population. So 0 on the y-axis represents the healthy population that does not have MS. And what you see on the far left in the upper corner are where individuals with MS start. They're clearly elevated on the Z-score scale. One of the nice things about a Z-score is rather than thinking of NFL as a single cutoff, which is above or below a particular level, is to recognize that there are features that can influence the NFL measurement, as I had said before, such as age, such as body mass index, and you can correct for that by generating these Z-scores and see where a person, for his or her age, for his or her BMI, fits in terms of normal versus elevated. And what you can see here is that if individuals are untreated, that is the upper trajectory, where there may be some decline over time just because when people come in to be assessed, they often have a problem and they may be more likely to have elevated NFL. So that's a regression to the mean in the untreated population, but you can see decreases in NFL levels over time, and there's a graded level of decrease that is based on the relative efficacy of the therapy. So the platform therapies will result in some decrease, but the higher efficacy therapies clearly are resulting in greater decreases, meaning moving towards the 0 Z-score line or normalizing these abnormal levels of NFL. So a nice feature of a good biomarker is response to therapy, and indeed DMTs can reduce NFL, and often you can see that effect within the first 6 months or certainly a year of treatment. So it can act as a marker of subclinical disease activity. And in fact, the greatest abnormal elevation of NFL is due to focal inflammatory disease activity. So relapse biology, whether you see it clinically or whether it is present subclinically, those focal perivascular inflammatory lesions are associated with a fairly large spilling out of NFL as a consequence of that injury. And it hence can be a real-time indicator, as noted here, of presence of disease activity. The question is so useful to replace MRI, and I think the answer to that is clearly no, and Jiwon had very compellingly made the point about the utility of MRIs, which are here to stay, and in fact utility is likely to grow. The question will be whether NFL can be used as an add-on to the armamentarium of assessing patients' state. And it is important, I think, to make sure that people understand what the utility is versus is not of NFL. As here in the US, more places are putting up a shingle saying, we'll measure your NFL and then discuss it with your clinician in terms of what it means. We want to make sure that people are not too caught up on a particular measurement like this. And as Jiwon had made the point before as well, there are aspects of measurements, imaging or fluid biomarkers that can play out very compellingly at a group level, but aren't necessarily going to translate to the level of the individual person sitting in front of you. So this is going to be part of our challenge for both NFL and subsequent fluid biomarkers in terms of incorporating into clinical practice. Now, another aspect of a good biomarker is whether it may have prognostic value, and it's very clear from several studies. This just happens to be the phase 3 Asclepios clinical trials of ofatumumab versus teriflunomide in relapsing multiple sclerosis, where the baseline measurement prior to randomization to either ofatumumab or teriflunomide was prognostic for on-study lesion development as well as brain volume loss. And this was a study that included several subgroup analyses, including assessing in this sizable number of over 1,500 patients, looking again at the serum level. And here, just saying very simply, anybody above 9.3 or below 9.3 picograms per mil, and asking how that played out in terms of prognostication. And those people who had the higher level clearly had more lesions and had greater brain volume loss. You could also look at the impact of age and body mass index, and both were incorporated here. And at the group level, this didn't particularly change the punchline, which was higher baseline serum NFL was associated with a greater rate of new disease activity, irrespective of age and BMI. This is not to say that age and BMI are irrelevant when you're trying to measure NFL in a single individual, but at the group level, this didn't seem to make an important difference. Next slide. Not advancing for some reason. Let me try this. Thank you. There we go. So here's a polling question for you. Please rethink your choice. Which of the following statements about NFL is most accurate? While not an MS-specific marker, NFL can be clinically useful in detecting CNS damage in MS. Number 2, rising serum NFL levels are a validated indicator of elevated risk for progression independent of relapse activity, or PIRA. Number 3, CSF NFL levels are more sensitive than serum NFL levels in detecting neuroaxonal injury. Number 4, oh, that was a little faster than my reading. Can we go back, please, on the slide? Are we able to go back one slide, please? Well, maybe for the sake of time, and I don't see that I can go backwards here. Is this a backwards? No. Folks, are we able to go back one slide or not? I just need an answer, please. We will continue, and please do your voting if you remember that. Oh, here we go. Thank you. So number 4, serum measurements of NFL are expected to eventually replace MRI in monitoring MS disease activity. And number 5, I'm not sure. Please go ahead and vote. And indeed, most people voted for, while not MS-specific, it may be clinically useful in detecting CNS damage, and that is correct, but a good number of people also voted for the PIRA question. I think that's a very important distinction that I'll be getting into. While NFL elevations are sensitive to focal inflammatory disease activity, the contribution of progression or smoldering disease in the absence of relapse activity to elevations in NFL is quite small, and it's actually rather difficult to distinguish. But this is relevant, and we can talk about further in the subsequent slides. So thinking beyond relapses, now is the question of PIRA, and this hopefully will help align that 20% or so of individuals with respect to the utility of NFL in this context. We recognize that MS as a disease spectrum is not either relapsing or progressive biologically, that the biology of relapsing disease and the biology of non-relapsing progression is present in most patients at the same time throughout decades of their MS. So while some people will still talk about patients transitioning from relapsing MS to secondary progressive MS, in fact, biologically, that is a myth that needs to be busted, because there is no magical day of transition. Rather, the biology of progression is present subclinically from early on. Relapse biology can be clinically evident or subclinical, and therefore may be present even later in the course when we don't see it, which is what we look for with the MRI monitoring. The question is whether NFL can add value, not just to detect what MRI can detect quite well, which is focal inflammatory disease activity, but also progression independent of relapse activity. And so this smoldering inflammation and degeneration is something that we lack direct capacity to measure, and is one of the gaps that we hope some of the biomarker field will help us address. Certainly fair to say that no means, including MRI, are yet validated for progression independent of relapse activity, as was demonstrated in the case that Jiwon had presented. And the question is, are there markers, perhaps fluid biomarkers, that may provide some help? And they've been studied now in several trials, and the question is, will they one day become a surrogate marker of treatment response, and how might we incorporate these measurements into clinical practice? And so one question would again be at the prognostication level or prediction level, and I want to make a point that when we talk about prediction, we're saying we want to understand what may happen in the future, but when you think about something like NFL, it's telling you what has already happened. Damage has happened, and damage is more likely to happen in someone in whom damage has happened versus hasn't happened. So we would love to have predictive biomarkers that identify a process that may lead to injury rather than a measurement that already reflects injury. So as useful as NFL will be, and we think it will have some utility in the clinic, it still represents something that is already a consequence of injury that may predict further injury. And indeed, NFL levels, when higher, are more likely to continue to be higher and more likely to be associated with further injury. This is a study. The slide is a rather busy one, but what they did here in a very elegant study looking at two large clinical cohorts. The left side of the table is the EPIC study cohort. The right side is the Swiss MS study. And they analyzed longitudinally in two cohorts from a long-term duration of follow-up, assessing the presence of higher levels of NFL. And what you can see again, when considering the Z-score, higher levels, higher numbers on the Z-score means greater elevations normalized to the healthy population. You can see that within 11 to 13 months prior to confirmed disability worsening, there were elevations detected in individuals with a relapse, and 12 to 20 months before confirmed disability worsening in individuals without relapse. So there was a longer lag time, if you like, or the need to follow up people for longer to be able to associate an elevation in NFL with subsequent confirmed disability worsening. Of course, we don't know whether the disability worsening was related to relapse contribution to progression of disability versus non-relapse associated progression, or PIRA. What about NFL measurements in individuals on high-efficacy therapy? And this may be a particular context in which elevations of NFL can be detected, and when detected, are informing us about non-relapsing progressive disease. And that is in the context of a study that was done as part of the Orchestra trial of ocrelizumab with anti-CD20, a high-efficacy therapy. And basically here, the measurement of NFL is not done before the initiation of treatment, but in individuals who have been on the ocrelizumab versus the active comparator for 48 weeks, so close to a year. So on high-efficacy therapy for about a year, and then the question is, can you look at high versus low and see what happens subsequently? And indeed, what you can see here, on the left, you're looking at the OPERA-1 and OPERA-2 in relapsing MS, on the right, the Oratorio study in primary progressive MS, and you see a very clear separation where on the y-axis you're looking at the probability of confirmed disability progression, which is clearly greater if your NFL on drug was higher, leading into the subsequent assessment of the clinical status. And what this suggests is that while in individuals who have relapse activity, it's difficult to pick out the contribution of non-relapsing progressive disease, this may be a particular context when someone is on a high-efficacy therapy that is suppressing relapse biology very effectively. Any added abnormality of NFL that emerges in spite of high-efficacy therapy may then inform more directly about the non-relapsing progressive disease. So this may indeed be one of the utilities of NFL in the future, and this needs to be validated in future cohorts. Now, NFL alone is unlikely to tell us the whole story. First of all, as I've already alluded to, NFL elevation does not distinguish between the cause of the injury, be it relapsing biology versus non-relapsing progressive. Even though relapse biology will contribute to higher elevations, it does not distinguish when you measure it, and you don't know how much of it is due to one biology or the other. So then the question is, can we add additional measures that might be more specific to the non-relapsing progressive biology of MS? And this is where GFAP, glial fibrillary acidic protein, comes biomarkers in. This is a study that leveraged data sets from the OBO cohort, which was a biomarker study, again, of individuals initiating the anti-CD20 ocrelizumab. And they had pre and on treatment CSF and blood serial assessments. And what we were interested in was the prospect of biomarkers that may distinguish these two biologies of MS, the relapse versus the non-relapse progressive biology. We measured 25 CSF markers, including NFL light chain, which is another one is NFH, which is the heavy aspect of the neurofilament, and GFAP and several others. And we'll focus here on the utility of GFAP and NFL. So NFL, again, in this cohort, as expected, strongly associated with the acute inflammatory disease activity, and to some extent with progressive non-relapsing outcomes. On the other hand, GFAP and neurofilament heavy chain, or NFH, tracked better with the non-relapsing progressive outcomes than with the acute relapsing biology, suggesting that they may have a complementary value when used perhaps in combination. And this indeed is something that now is being looked at in large prospective cohorts. And I think there is a good prospect that we will ultimately be measuring the combination of NFL and GFAP as a way perhaps of assessing in an individual to what extent is relapse biology present, to what extent is non-relapsing progressive biology, and that will be particularly important if and when we have treatments that are more effective for non-relapsing progressive disease. And so in one such study, still a relatively small study, but a prospective observational study, trying to understand the association between these biomarkers in the serum and disease progression. You can see the numbers of individuals here with both primary progressive MS and secondary progressive MS who were followed for approximately 30 months on average, and they used 6-month confirmed disability progression using EDSS, time 25 foot walk and 9-hole peg test, and high levels of GFAP and low levels of NFL. So if you have high GFAP and at the same time relatively low levels of NFL, that was a context in which you were most likely to associate with non-relapsing progressive disease, so non-active progressive MS. So the integration of the fluid biomarkers is something that we've tried to create algorithms for. The CMSC, who's hosting us here, has an algorithm that I think is useful, certainly a useful start. It's shown here in a small scale on the left-hand side, but I'll go through each of the 3 components, starting with the top component, which suggests that when you're evaluating someone diagnostically at baseline, you're able to assess, of course, the imaging parameters that G1 had nicely overviewed. You'll look at spinal fluid, often, not always, and potentially blood. And of course, you'll do your neurological exam, and you will look at the McDonald criteria to establish a diagnosis of multiple sclerosis. And we still will be using, I think, these clinical monikers of relapsing MS and progressive forms of MS, even though, again, we recognize that both these biologies coexist in most patients throughout much of their course. But here we have the potential utility of a combination of measures, imaging, clinical, and potentially biomarkers in the context of diagnosis. I don't think NFL is going to be particularly useful, or GFAP particularly useful, in the context of diagnosing MS, because while it may be relatively sensitive to damage, it is clearly not specific, either one of them. But then when it comes to determining severity and prognosis, a question is, could we use, for instance, NFL, an elevation of NFL, early on to predict how the course of the individual will proceed? So here we're looking again at the combination of the MRI and the neuroexam, and then the question of whether NFL, in the context of whatever the imaging and clinical presentation shows, NFL being either normal or elevated. And so if things fit with a relatively mild course of multiple sclerosis or a typical course, you will start any choice of DMT. But if you have the same imaging and clinical presentation with clearly elevated NFL, you might be more concerned prognostically, and you might be more swayed to discuss the initiation of a high-efficacy therapy with that individual. And of course, for patients with primary progressive MS, we are limited to date with respect to approved therapies. Then the question comes in terms of whether NFL could be incorporated in the algorithm for monitoring of individuals. And here, many of us follow patients every 6 to 12 months, and we will again assess the clinical status of the person, try to follow them in terms of their neurological exam, and ask them how they're doing, and use the MRI. And again, the question is, can we incorporate NFL in this context and consider it either stable or elevated? And for any context of the clinical and the imaging presentation, the NFL could either be normal or elevated, and if it's stable over time, we would continue the current therapy. There would be no compelling reason to change. But if we have either clinical evidence, imaging evidence of new disease activity, or perhaps an elevated NFL, we will probably want to make sure that elevation is likely from MS and consider the other reasons why NFL may be elevated. But if we do think the elevated NFL is attributable to multiple sclerosis injury, we will be in a position to consider a switch and an escalation of treatment. And so I'm going to pass the baton on to Jiwon as we move from neurofilament and GFAP considerations to a couple of the other prospective approaches to monitoring patients over time. Jiwon, please.
Thank you, Amit. So last couple slides, I think we've covered a lot of topics, so really early in the morning. We talked about imaging biomarkers. Amit gave an outstanding overview of some emerging fluid biomarkers. And then another tool that we may have in our pockets in the near future might be some digital tools. And you probably hear about at different congresses many different devices, whether they're on the smartphone or on an iPad, that are being tested right now to see if they will allow us to monitor in more detail disease progression in people living with MS. So as you can see, starting about 7 years ago, the amount of literature on different digital tools has really increased over time, which is really good news because the more tools that are tested, the more likely it is that something will become available in clinical practice pretty soon. There's many different kinds of tools, including those that assess gait, those that assess voice, as well as those that assess cognition. And most of the tools are focused on gait. However, there's a wide range of tools, and many focus on many different aspects of disease. So Floodlight is an example of a tool that has some published literature on it, which is why I'm focusing on it. But this was actually a smartphone app that was launched around the world and was freely available for download, mainly on the iOS platform, but later the Android platform. And it was an interesting test because it allowed people to do these tests on their phone on their own time. And it included tests that looked at manual dexterity, coordination. It looked at walking tests as well, and had questionnaires that evaluated cognition as well as mood and fatigue. So this is just a pictorial diagram showing what the Floodlight app looked at. And so as you can see, lots of different tests that were able to evaluate different aspects of MS, many which are very important to people living with MS, including cognition, mood, as well as detailed tests looking at motor coordination and things like gait. So the interesting thing is this Floodlight app is no longer available, but I think important to think about just because it teaches us what we need for the future. So when this app was launched, there was high interest, downloaded around the world. But I think one of the most important stories that we've learned from this device is that, as you can see, within about a month of download, there's a precipitous drop of how often people actually use the device. So if you think about how you use smartphone apps, this makes sense because, at first you're excited, you download it. A lot of people actually in the process of downloading and actually launching the app, there were all of these steps that needed to be done. They didn't even bother. But the people that started using the app, there was some use within the first couple weeks, but it was over 80% of people that stopped using the device altogether within a month. So I think really important to note, because we need to keep in mind that a device is only useful if people actually comply to using it. And so this is something we need to keep in mind. If it's too complicated, if there's too many things, if it's too annoying, if you keep getting all of these notifications, then people will just simply stop using the app. The interesting thing was, as you can see in this diagram, there was one country that stood out that was actually much more compliant to the Floodlight app, and this was Denmark. And the reason for this is because this app was linked to a national study that they were doing, and there was clinical oversight. And patients were committed to using the device because they knew they would be seeing their neurologist and their research coordinator and would be asked about this. So I think lots of lessons to be learned here, just because, again, we need to figure out something that people will use and voluntarily, because the point of these devices is it's something that monitors different aspects of disease regularly and gives us a much better gauge of how people are doing on a daily basis, but it's only useful, again, if people actually use the device. There's also eye movement tests that are being evaluated using iPads as well as different digital devices. And in a very recent study with an eye movement device that was evaluated using an iPad, there were strong correlations with some of the measures that we already accept as relevant to disability in people with MS, including EDSS, different cognitive tests, MSFC. And so I think these are all examples of tools that are emerging that will be very useful, because the way we currently monitor clinical disease progression is far from perfect and really needs improvement. As I outlined in that case that I just discussed with you, the EDSS score will always remain stable in people with very subtle disability progression, and this is why we need some of these digital tools that allow us to sample people at regular time intervals in between their clinical visits. It allows us to capture, subtle change as well as the variability in some of these measures that happens over time. So lots of digital tools, again, nothing that we are currently using in clinical practice. And the steps that are needed before we can use any of these tools is, first of all, we need to validate them against existing measures to be convinced that they are relevant. We also need to figure out what is the threshold for, say, a pinch the tomato test that would raise concern in an individual patient. And, as a neurologist, with some of these tools, I always worry that people will show up in clinic with like lines and lines of numbers of, different changes that they've had, and when I don't know exactly what to do with a number, it actually doesn't become very useful and actually almost like a hindrance in clinical care. So some of these threshold issues need to be defined, and the timing that we need to figure out in between different measurements. So these are all kind of logistical and technical pieces that we need to figure out for any of these digital tools before they will become useful in clinical practice. But as you can imagine, there is so much potential for some of these digital biomarkers. So in addition to the fluid biomarkers that Amit talked about and some of the emerging imaging biomarkers, these are the things that hopefully in the years we'll have available to better monitor people living with MS. So let's go back to that case, Sierra. Just as a reminder, this is someone who's had MS for 6 years, really active disease at the beginning, was started on an anti-CD20 agent, has been very stable from a relapse and MRI standpoint, but she's telling me, and my EDSS score is still stable, but she's telling me that she can no longer hike as far as she used to, and it's very clear that she is demonstrating evidence of smoldering disease or progression independent of relapse activity. So Amit, if I can ask you, based on all of the data that you presented to us, many data pieces really compelling, what biomarkers, fluid biomarkers, alone or in combination, do you think may be useful for Sierra, with the understanding that right now we don't use them in clinical practice, but what do you think?
Yeah, no, I think as of today, we're not ready to use them, but I do think that the combination of NFL and GFAP may be useful. One would predict that in someone with this scenario, that there would be an elevation in GFAP, which is more specific for non-relapsing progressive disease. There may be some relatively small elevation also in NFL. Again, the likelihood while on high efficacy therapy for there to be a substantial amount of relapse biology contributing is relatively low, so that's likely to be the profile. And I think measuring in individuals over time, this combination will eventually give us a sense, an insight into the utility, but we will still need to overcome some of the issues of which platform is going to be used, how to interpret, how to adjust for aspects that non-specifically contribute to elevations, both of NFL that we know more about and GFAP that we're still learning about.
And I think one of the slides you presented with in the clinical trial setting, people who had been on an anti-CD20 agent, once you effectively suppress almost all of the relapse disease activity, NFL did appear to be related to subsequent development of PIRA.
Exactly.
I think one of the challenges we have in the imaging world is, something that very clearly is applicable to huge groups of patients often is not as easily applicable to individuals. So what do you think about that? Because based on the curves you showed, it looked really compelling.
It's compelling at the group level. The issue is that the level of abnormality that you're likely to detect in that context is a relatively mild elevation of NFL, and there are multiple other things that can contribute to a similar degree of elevation of NFL, including bumping your head, having some chronic disease that is going to be more and more likely in individuals who are less young and over time accumulate comorbidities. Those comorbidities that they will likely have are the very ones that are likely to contribute also to elevations in NFL that are not MS related.
All right. So I hope we've been able to give you an overview this morning. I know it was a lot of data about how there are many different emerging biomarkers, including imaging biomarkers, fluid biomarkers, digital biomarkers, that hopefully can help us in the future to guide treatment decisions. However, right now we do have some biomarkers available, and one of the most valuable imaging biomarkers that we currently use are typical clinical MRIs, where we're looking for new lesions or baseline MRI lesion load. But as you heard, there are many different things on the horizon. So hopefully when we have this symposium in a couple years, we'll be talking about some of these tools that we talked about and how we use them in clinical practice. So I know that we're a little bit over time, but there were many questions that came in from the audience, and I just want to maybe take the time to answer one or two of them, if that's okay. Let me ask. Amit, one of our participants asked, if you do use NFL in clinical practice, and you kind of alluded to this in some of the slides, how often should they be measured?
Yeah. So first to say that we are not routinely measuring NFL in clinical practice. We're waiting to see what the guidelines. We're actually involved in trying to figure out what guidelines would be most appropriate for NFL. The frequency, though, that is likely to be useful is NFL measurements perhaps every 3 months or so. And I say that because what we've learned in terms of the half-life of NFL, in other words, if there's an elevation because of injury, how long does that elevation from that injury stay? And it's likely that within 2 to 3 months, whatever contributed to that elevation will no longer be the cause of further elevation. And if you imagine that you did that in places, for instance, that don't have access to MRI, will NFL be actually a more practical, perhaps more affordable approach to monitoring for focal inflammatory disease activity, which is what it best captures in the context of disease state.
And then there's another question from the audience. What do you think about the recommendation for annual MRIs in the era of highly effective DMTs? A large majority of patients on highly effective treatments have no activity or changes on standard 1.5 Tesla MRI. So maybe I can start.
Yeah.
So I think it's still extremely important to monitor people, even on high efficacy therapy, where we know the likelihood of having a new MRI lesion is pretty low. But, you know, just to make sure, it's really important to still monitor on an annual basis. And there are also safety reasons why we use to monitor with MRI as well. So I would say that annual recommendation, regardless of what type of therapy you're on and the likelihood of new disease activity being high or low, it's still essential. On a minimal basis, you should still be monitoring annually. I mean,
yeah, I think that's sort of our message in general to patients. Certainly there are individuals who hate MRIs and they just struggle with every MRI that we do. We don't want them to end up being less well monitored than others, but we have in individuals who have been very stable for years and years on high efficacy therapy, ratcheted back and increased or decreased the frequency or increased the gap to 1.5 to 2 years. But that's always a discussion that's sort of a case by case.
Okay. Just one last question, just because it's interesting. Do you think that the lack of actual biomarkers for neurodegeneration are responsible for the failure of evobrutinib in the clinical trial? Yeah,
that's a really interesting question. I think that we will be, in the future, doing a better job assessing people in clinical trials with the addition of fluid biomarkers and additional imaging measures that you mentioned, perhaps some other digital tools. The Evolution 1 and 2 studies were focusing on relapsing MS outcomes. And those are outcomes that we're actually pretty good at measuring with the tools that we have today. So I don't know that even if we had tools incorporated into the trial, that it would influence the primary outcome measure of the study. But of course, it is possible that evobrutinib, while demonstrating what appears to be a pretty modest effect on relapse biology, nonetheless might do something to the non-relapsing progressive disease. And that's really our hope with the subsequent BTK inhibitors, that they may impact not just the relapsing disease activity, and even if they did that modestly or moderately, that they will have an impact on CNS compartmentalized inflammation and progressive disease. That still remains a very important gap that BTKIs may address in the future.
Okay. Well, I just want to wrap up our session today by first thanking Amit for being such an excellent co-chair and faculty member.
And G1 for the same.
And wanted to thank all of you for your attention and your participation and for sticking with us even 10 minutes over time. And then just wanted to remind you to please remember to complete your post-test and evaluation for CME credits. And then you can use the QR codes on your tables to access all of these items. Thank you very much for your attention and enjoy the rest of the meeting.
Thank you. Enjoyed the day.